To this point, I have answered the questions in print, but this one needs a video. Why? Bad news must be conveyed personally, and discussing it with you requires it too. First, it's as much as how you break the bad news as what you actually say when you do. It must be personal. No phone calls, no texts, no voicemails, no messages from the secretary. There's a rich patient literature in these techniques, and they're abuses. It must be private. Can't occur in a recovery room or in a crowded clinic. This is one of the rare times patients and their families should be ushered into the inner sanctum, the Holy of Holies, your private office. It must be a person-to-person as much as a doctor-to-patient experience. Encourage close family members to be present. They'll help you and help the patient. Patient should be seated and be an eye level with the patient, not looming over them like some Easter Island monolith. It's best to be in adjoining chairs rather than being separated by the geographic and status divide a large desk puts in the way. Being in proximity allows the last of the communication techniques that precedes the actual verbal communication, the laying on of hands. Touch as well as eye contact is needed right from the start. That hand on the arm means a lot, and it's rare. I've written extensively on empathy. I've tried to explain to readers that doctors really can't feel their pain and shouldn't feel their pain. It inhibits clinical activities during crises, and doctors would burn out even faster than they do now. Remember, one of the most important things we do while trying to help patients is actually hurting them. But there's a time, if it can't come naturally, to perform empathic activities by acting empathic, faking it. And I've called it genuine artifice. It's so simple. It's the sigh, the arched eyebrows, the downcast gaze. There are as many doctors who will have to fake it as those who don't even bother to show it. Then comes the talk. Bad news comes in many degrees of severity. Providers should be aware that what might not be thought of as bad news to some may be devastating news to others. Err on the side of assuming the news will be hard taken, and prepare for displays of emotion. Tissues, a glass of water, and a staffer somewhere nearby are helpful. As my answer to question 4 notes, if all the routine activities that doctors perform are each put on a protocol, doctors won't have to reinvent the wheel every time an anticipated job we routinely perform is needed. It's all in place. Chefs call it mise en place. Assuming that we're telling a patient that they have a disease that is expected to end their lives, I don't offer a time frame on the first visit. Please follow this link from writer and paleontologist Stephen Jay Gould. It's famous. The median is not the message. It's how he coped with a fatal disease and won. Patients should also receive a copy of this monograph at some point, because sooner or later they will all read or hear from other providers about their median survival. This statistic is often used and could not be more misleading to the individual patient. Please also refer to a blog I wrote. Just Google medical advocate predicting death. We're bad about talking about death and worse when trying to predict it. We can't and we shouldn't, and certainly not when breaking bad news on the first visit. Too much is not needed during the first encounter, so little will be remembered. Yes, there's bad news. You do have the cancer you and I were worried about. And now we have to act together against it. We're going to assemble a team. We're going to get the best opinions and leave no stone unturned to fight this. The patients are going to ask, am I going to die? And the answer for me has evolved over time. If there is to be a cure, we'll find it. But it's simply too early to read the future now. We're going to be talking regularly, but we're going to have to let at least 6 months to a year pass before we can answer the ultimate questions you have. It's then that we can look back and plan forward. I and my office are always here to answer your questions and field your concerns. And here's the private number to our office. It's just for you. Aside from the mechanics of the referrals and appointments, that's it. I use this discussion as a mantra and won't allow myself, however understandably the patients want to know more, to get sucked into the flurry of questions that demands more information that I don't have. I know you want to know. I know you need to know. You deserve to know. But right now there's simply no way to know. Time is going to determine much of what you ask. There is, however forbidding a prognosis, plenty of time to address a patient's existential worries. Even if I don't think the patient has a year to live, on the first day, who am I to say?